Today we're in Minneapolis in Minnesota with a excellent colorectal unit from the University of Minnesota. So I thank them for their time. This is our team. Of course, Dr. Galandiak is the editor-in-chief for the journal. So we thank her for her leadership. As well as this, we've added the sort of a little background of why we're late is that we've had some security concerns. I don't think it was quite like Fight Club, the movie, but at the same time, we do want to make sure that the content of the recordings and the live sessions are appropriate. And as we have grown from firstly just having the one English journal club to now having 4 foreign language discussion forums, unfortunately, so has kind of maybe the interest in hacking them. I guess we can take that as a compliment. We do apologize for some of the extra challenges of updating the securities, and we are working through it, and hopefully we will minimize everyone's challenges as we get better at this. So just the webinar etiquette. Our aim is to ensure that everyone has an opportunity to ask questions and have those questions answered. Minneapolis, as is my custom, a fun fact about Minneapolis. Interestingly, I found that it's the second highest theater seats per capita in the US after New York City, and it is home to the oldest continuous running theater in America, which was formed in 1921. I am particularly partial to musicals, so I would find that incredibly exciting, hopefully some of you as well. Now, to a little bit more of a serious note, I would like to make a special mention of Professor Wolfgang Gaertner. He is the chief of the Colon Rectal Surgical Division. I will share sort of a little bit more of a detailed summary of his achievements later, as he is our special guest. But for now, I'd be grateful if he can sort of introduce us to his city, to his department and his institution. Thank you very much.
Thanks, Vlad, for the invitation. And I would say it's the #1 per capita when it comes to public golf courses in the entire country as well. But thank you so much to everybody from DCR and ASCRS for the invitation and highlighting our division. We have the oldest colorectal fellowship training program in the country, one of the longest ongoing course for colorectal surgery. This upcoming year is going to be our 83rd year of doing the colorectal course. It's a unique division in the fact that we have a very large private practice component to our division, as well as those who are at the university. We have 5 fellows per year, robust training program with general surgery, obviously, with a lot of general surgery residents that are involved in research, which we'll highlight today. I am not from Minneapolis, as many know me. I'm originally from Vancouver, Canada. I trained here, so I'm a double gopher, both in general surgery and colorectal surgery. But Minnesota is kind of one of those cities that when you're here for a while and you adapt to the cold, it kind of pulls you in and doesn't let you go. I came to Minneapolis to become a transplant surgeon. And when I met Stan Goldberg, David Rothenberger, and Rob Madoff, I immediately changed that path to colorectal surgery. I left for a couple of years and came back, and I've been here ever since. And that's pretty much what I wanted to highlight.
And so this is the panel for today. Would you mind just sort of just summarizing the who we have in terms of the participants, please?
Of course. So our discussants tonight, I know Dr. Goffredo is still kind of trying to log in. I know he's probably going crazy on his computer and his phone right now, but we do have our program director, Dr. Mark Sun, who's also an adjunct professor of surgery at the university. He has been our program director. What has it been now, Mark, has it been 11 years, 10, 11 years? Almost 10. A decade, 10 years. Congratulations on that. Mark has been just like a pillar for us within the division and our training program. Anybody that has been through Minneapolis knows Mark's son. And so he will be helping the discussion with Catherine Tran, who's one of our fellows this year. Catherine comes to us from the University of Iowa, from which Dr. Goffredo came from in the past. There's kind of like an Iowa connection even to this journal club, actually, with Alex as well. But Catherine is one of our current fellows. Our other discussant is an assistant professor of surgery, Dr. Paolo Goffredo, who's originally from Milano, and he trained at University of Iowa in general surgery. then came to us for colorectal fellowship. He went to MSK with Julio for a year after that. Then Rob Madoff sent him to Australia to do more specialization in pelvic exoneration and locally advanced rectal cancer, recurrent pelvic cancers. And now he's just doing an unbelievable job with our research as our research director of our entire division. And last but not least is Alex Troster, who is a third-year general surgery resident that's in his second year of lab now. So essentially he's a fifth-year general surgery resident that's also from the University of Iowa from medical school and has a big interest in colorectal surgery, is now presented at multiple venues, and we're hopeful that he will join us as a colleague soon.
Fantastic. Thank you very much. So the next slide is our poll. So please feel free to fill it out. Now, the question is, how many of your colorectal patients have died from a venous thromboembolism? Great. And whilst we're doing that, let's move to the next slide. So the next slide is the first article. So the title is Room for Improvement, the Impact of Guideline Recommended Extended Thromboprophylaxis in Patients Undergoing Abdominal Surgery for Colorectal and Anal Cancer in a Tertiary Referral Center. This paper comes from the Mayo Clinic, specifically Mayo, Florida and Arizona groups, with Dr. Sasha Brocard being the first author. And the paper will be presented by Dr. Catherine Tran, and then we'll have the expert commentary from Dr. Mark Sun. So thank you very much, and please start when you're ready.
Thank you, Dr. Bolshinsky. Thank you to the DC&R Journal Club team for the opportunity to present and the invitation. We really appreciate it. Next slide. As some background, the rate of venous thromboembolic events after abdominal and pelvic colorectal surgery is about 2 to 4%. And data have shown that extended VTE prophylaxis after surgery for GI cancer does decrease the rates of VTEs. So as a result, ASCRS clinical practice guidelines do recommend 4 weeks of extended VTE prophylaxis in high-risk patients, that is, patients with a Caprini score of at least 5. Next slide. However, unfortunately, prior studies have demonstrated that the rate of actual appropriate VTE prophylaxis is quite low. So this study sought to determine the impact of appropriate versus inappropriate VTE prophylaxis on VTE rates and rates of bleeding after surgery for colorectal and for anal cancer. Next slide. This was an observational retrospective study. It covered 3 institutions, all the Mayo institutions, and the inclusion criteria were adults admitted after elective abdominal or pelvic surgery for colorectal or for anal cancer. The primary outcome was rates of appropriate prophylaxis based on the Caprini score, so that was calculated for each patient. And then the secondary outcomes were rates of DVTs, PEs, fatalities, bleeding rates. And then the patients were also analyzed in 2 groups, as an inpatient and then post-discharge. So there were 2 analyses that this study did. Next slide. With regards to the percentage of patients who actually received appropriate DVT prophylaxis inpatient, that was about 63%. Post-discharge, those patients, only 2% of them received the appropriate VTE prophylaxis. Looking specifically at the inpatient results, there was a difference in DVT and PE rates between patients who received appropriate versus inappropriate DVT prophylaxis. Patients who received appropriate prophylaxis had lower rates of DVT and lower rates of PE. There were no differences in fatality, and the appropriate group did have lower rates of bleeding. However, this is likely because patients who had a bleeding event likely had their DVT prophylaxis stopped and therefore were analyzed as part of the not appropriate DVT prophylaxis. Post-discharge, again, only 2% of patients received the appropriate DVT prophylaxis after they were discharged after surgery. There were no differences in DVT or PE rates between the 2 groups. There were no differences in fatality. And then importantly, there were no differences in bleeding rates between the patients who received their appropriate DVT prophylaxis and those who did not. Next slide. So in conclusion, the rates of appropriate DVT prophylaxis is low, especially post-discharge. Appropriate inpatient prophylaxis is associated with lower rates of DVTs and PEs. And finally, post-discharge prophylaxis is not associated with increased risk of bleeding after discharge. Some limitations of this study were that it was a retrospective study. it was a single healthcare system, so they likely have a kind of a similar system for how they do things. And then it does rely on data being accurately entered into the EMR. Thank you again for the opportunity to present. I look forward to the questions and discussion.
Thank you very much for that. Dr. Sun, would you mind saying a few words on your take on the paper? Thank you.
Yeah, I mean, so obviously this paper has a few limitations based on a single institution retrospective nature. It's when reading something like this with only a 60% inpatient adherence to proper VTE prophylaxis, that number seems extremely low, especially in a relatively modern age. I mean, this paper was captured between 2016 and 2021. What do you think of that, Catherine? The fact that only half the patients actually got appropriate VTE as an inpatient?
Yeah, I think a lot of it is up to surgeon discretion. And so I think part of it is sometimes, as a fellow, we'll talk to staff and the case was kind of oozy or the patient's high risk or we have some other concerns. And so I think sometimes we do have to make a clinical decision to hold DVT prophylaxis that to us seems appropriate, but in this paper makes it seem like it's an inappropriate. It's listed as an inappropriate decision.
Yeah, I mean, that certainly happens that there's left to individual discretion. 40% discretion seems awfully high, though. Did they go into, I was trying to look into their methods. Did they go into more detail in terms of how they identified these patients? It's just simply by the med reconciliation as an inpatient based on their inpatient medical record system?
Yeah, that's correct. So they said that they did make a point that they meticulously reviewed the EMR of each patient that to make sure that they got their SCDs and their appropriate DVT prophylaxis.
Yeah. I mean, if that's really true, I mean, that's awfully low. I don't know about the rest of the panelists. I mean, I can't imagine only 60% of our patients as an inpatient receiving appropriate DVT prophylaxis. I mean, certainly we hold it sometimes for bleeding risks, but not 40%. So like that already, that number like bears some amount of explanation why they think that number is so low. Like, that one just sets off like a red flag for me. The other things like, I mean, if they're truly their inpatient adherence rate is only 60%, it doesn't surprise me why their outpatient like adherence rate is so low as well. The other part about this is, coming from Mayo is that just knowing about the Mayo, like, I don't know how it is in Florida and Arizona, but this is a very unique practice, at least within Minnesota, because they get so many patients that come in from elsewhere. So this is especially true, us being in the Twin Cities. A lot of patients go down to Mayo for their surgery and then they don't get their post-op care there. So the rate of actual VTE is so low, but I don't know how accurate that is because again, a lot of those patients end up coming to see like places at like Minnesota, University of Minnesota, or like our outlying hospitals in the Twin Cities rather than going back to the Mayo. So I think that there's going to be a fair amount of bias in terms of how they recapture these events that is going to be impossible within their system. And I think that's one of the critiques, historically of some of the Mayo papers is that the outpatient follow-up, longer-term follow-up, I think is a little bit more difficult just because of the unique nature of their health system.
Yeah, I would. I'm just going to chime in really quick, but I mean, certainly, I think there is a trend of seeing less post-operative VTEs, not just for colorectal surgery, but for other disciplines. If you've read anything recent about post-operative VTEs, it's on the downtrend, even for patients with slightly higher risk. The first thing that comes to my mind, even with a large cohort like this, is first of all, were the patients they were healthy and they didn't have a lot of risk factors, which the majority of these patients had a Caprini score less than 5, right? So that's from the start. And what was the real follow-up? I think that really needs to be driven home. What Dr. Sun said about sometimes the lack of follow-up with Mayo afterwards, that they may not capture that rate of DVT or PEs afterwards.
Thank you.
Oh, sorry. Oh, yeah. I was just gonna make a quick comment as well. That the true rate is very low. It's probably less than 1%. we quote often up to 10% as the rate of post-colorectal DVT, but that's driven by those trials that were actually looking for screening detected ultrasound DVTs. When you take that out of the question, you only look at the symptomatic ones, that numbers is 10 times lower, as we're seeing in this paper, together with the limitations, of course.
Yeah, to sort of build on that, now these authors comment that at the in the cohort that did not comply with extended DVT prophylaxis, at 90 days post-discharge, the rate of DVT, PE, and VTE in general was 0.62%, 0.4%, and 0.88%. And so I went and tried to PubMed a paper that may compare this or juxtapose this to the incidence of DVTs, PEs in colorectal cancer patients, say in 6 months before they got diagnosed with their disease. And interestingly, there's a paper from 2021 from the Journal of Hemostasis and Thrombosis. The paper's titled Venous Thromboembolism in Cancer Patients, a Population-Based Cohort. And that study quotes an incidence of VTE in colon cancer being 1.08%, and the incidence of VTE in rectal cancer, so 6 months before diagnosis, as being 0.51%. So if you believe the accuracy of these papers, the incidence of VTE is higher before they get diagnosed than in the post-operative period, which kind of, to me, lends a question of, is our sample of analysis just too small, and it's relatively, meaningless in the bigger picture. What do you think of that? Anyone from the panel?
I don't have much more to say than to agree with you, but I mean, when I think about these cases, it's so meticulous on how we have to assess the granular detail that brings a patient a higher risk of VTE, and we do such a poor job at stratifying DVT risk within our patient group. Like even for pelvic surgery status post, let's say chemoradiation, we don't have a good system where we can prioritize the need and the risk and pros and cons of chemical DVT prophylaxis, right? I mean, it was like 10, 15 years ago, all these publications came out that we were seeing all these DVT risks in cancer and somewhat IBD patients. And all of a sudden, this just blanket statement came out that we have to give everybody 30 days. So we don't have any idea of what the best agent is or duration or anything on that. And I just feel like we've just had a lack of prioritizing or stratifying the risk and giving the patients the right treatment.
Thank you. From a ASCAR's CPG perspective, I think if one looks at the two most recent guidelines, the strength or the impetus to adhere to extended DVT prophylaxis has actually been loosened a bit, as far as I understand. And would you mind sort of kind of showing us under the hood, or talking about how do you get to that decision?
Yeah, I mean, the CPG committee its biggest job is not having an expert in VTEs write the VTE prophylaxis guideline. We're there to assess the data and present the data in an unbiased way for our membership and for the global surgery community, right? And nowadays, with evidence and data, you can be in Australia, Germany, Mexico, or Minneapolis, and we all have rapid access to data, right? So we're writing these guidelines based on English language data, which can have flaws as well. But to the under the hood kind of situation, I think what we're going to see is probably more robust randomized control data with stratification of risk of DVT that's going to help us indicate it as who needs prophylaxis, how long it is, and probably loosening of the guidelines perhaps for IBD patients, where I think we have the poorest data when it comes to extended chemical prophylaxis. That's why that guideline is a 1C grade compared to the 1A, 1B for cancer, for example. But there's so many other granular details that have to be factored into that. And I think that evidence is going to change rapidly, almost to the point where, and this is what we're working on from a CPG standpoint, is to have almost like a live document that can change depending on what level of data we have.
Thank you. Two more quick questions in terms of how your team manages this. The first question, we've touched upon the Caprini score. Is that something which is integrated into your decision making, or is it, people do their own thing? And the second question, and they are separate, is the timing of perioperative chemoprophylaxis. Specifically, if you look at this study, they comment that use of anticoagulants for chemoprophylaxis was confirmed if any of the anticoagulants outlined were documented as used on the day of surgery or post-operative day 1. To me, that's quite a big net to cast, on table or 24 hours later. So yeah, both questions. So the score, and also when do you give chemoprophylaxis?
I'm going to pass that on to Mark or Paolo.
Yeah, I don't know that there's, I haven't worked with some of the people within our division in a while, and we're a big group. I don't know that anyone that actually formalizes a Caprini score. We generally use it, if someone is on an anticoagulant pre-op for whatever indication, whether that's AFib, a valve, et cetera, we usually just restart that anticoagulant and they don't get like any sort of like additional chemoprophylaxis. For everyone else that's not on something at baseline, generally we send them home with just Lovenox. And I think for all of us, we start that pre-op. So within all of our order sets, they get a pre-op dose of sub-Q heparin in the pre-op area, and then they start getting their post-op doses immediately thereafter. I like our group, at least within our hospital system, we start with Lovenox on post-op day 1. So, and then everyone goes home with that. So that again is part of one of our, like, it's on our discharges that for IBD and for cancer patients, everyone goes home with that. I agree with Wolf that I think that the data out there, it's marginal in terms of how much or how necessary it actually is. I think the reason why it's so widely accepted is because a prophylactic dose of Lovenox is so low risk. It adds some cost to the care of that patient in the post-op bundle, but on the whole, it is like a minimal risk indication, and the chance of someone developing a major bleed on a prophylactic dose is so low. I think that's why the majority has been willing to adopt this into their practice, even though the data is not hard. And like, I don't know that the data will ever be hard because it's such a low risk intervention that I don't know that someone's gonna, invest, hundreds of thousands of dollars or millions of dollars into a randomized, trial to actually like suss that out when it's something that people are willing to do to start with.
I agree. The risk is very small, but at the same time, it's associated with a lot of anxiety for the patient that need to poke themselves for 30 days, and there is cost with that. In this study, the number needed to treat was 115. So definitely a lot of unnecessary pokes. You multiply that for 30 days. I think it's very mandatory in this DNH to really select the patients that we're sending home on DVT prophylaxis. It should not be a blanket for everybody, but we should be more careful and selective. I do not send everybody home, but I also do not use the Caprini score.
Yeah.
Thank you.
That comment you brought up, Vlad, though, just to expand on that, like the inclusion criteria of the first dose within 24 hours is fascinating, because if you look at how much a preoperative dose can actually translate into prevention, if you look at the pelvic, especially urologic literature and orthopedic literature, where they did sequential lower extremity duplex ultrasounds on these patients for almost a week. 60% of blood clots that form in the lower extremities that will become a VTE will form within the first 24 to 36 hours. So how much importance are we going to give that first dose preoperatively, where we know that there's more stasis and probably more exchange of blood factors or stress from surgery within the first 24 hours? I just feel like there's so many good opportunities to study and research this topic that we've just come out, blazing kind of guns with giving everybody 30 days, that we really don't know those just natural questions that we would ask ourselves for almost any other disease process.
Yeah, thank you. I agree. I thought a similar analogy is in trauma surgery, because a lot of the patients that present with DVT at presentation already. At the interest of time, let's move on to the second paper, please. And so our second paper is called Low Dose Rivaroxaban as Extended Prophylaxis Reduces Post-Discharge Venous Thromboembolism in Patients with Malignancy and IBD. This paper comes to us from Michigan, with Dr. James Ogilvie being the first author, and it'll be presented by Dr. Alex Troster, and then we have expert commentary by Dr. Goffredo. Thank you very much. Start when you're ready.
Thank you to the Society, as Catherine said, for allowing us to present. You can go to the next slide, please. As was alluded to, the VTE incidence around major abdominal surgery is around 2 to 4% in the literature. And as was previously discussed, the current clinical practice guidelines for colorectal cancer are conditional based on high quality evidence, while IBD is conditional based on very low quality evidence. And it's worth pointing out that these are all for using Lovenox as the prophylactic measure. Next slide, please. In this paper, this single institution identified some potential barriers to Lovenox as extended prophylaxis, being the low adoption of and adherence rates, as well as patient compliance with daily injections that was talked about as well. And so they expanded on some advantages of direct oral anticoagulants, specifically rivaroxaban being an oral once daily pill. And then in the orthopedic literature, which was sort of talked about in a phase 3 trial, there was a statistically significant reduction in VTE in the extended period. However, there should be noted that there's no reversal agent for these direct oral anticoagulants, which is a major disadvantage. And so this paper looked at what was the impact of once daily rivaroxaban for the 30-day period on VTE rates after colorectal cancer or IBD surgery compared to no extended prophylaxis. Next slide, please. This was a single institution retrospective study of 6 surgeons. Every patient got a dose of preoperative subcutaneous heparin, 5,000 units, that was continued through the postoperative period, either twice or 3 times daily based on BMI, as well as mechanical prophylaxis with SCDs. The primary outcome was VTE by ICD-9 codes, looking at VTE location, the diagnosis time from surgery, whether it would occur in the hospital versus outpatient. However, there was a failure to describe whether the DVT was symptomatic or asymptomatic that was detected on the screening ultrasound or other study. And the primary harm that was looked at was 30-day bleeding rates. They stratified it into minor bleeding rates and major, minor being just stopping the anticoagulation, and major bleeding rates needed further intervention. Next slide, please. This was the figure of the cohorts. I'm looking at a historical cohort of 184 patients between May of 2012 and 2014, and then comparing that to the prospectively collected cohort that was May 2014 through July 2016. They then did a propensity score matching of 174 patients in each arm and excluded patients who had inpatient VTEs to finally arrive at the final cohorts of 168 patients that had post-discharge data. It should be noted here that the post-discharge propensity score matching of the prospective cohort included patients that both were on baseline anticoagulation without a explanation for their underlying diagnosis or need, as well as patients who were on no anticoagulation. Next slide, please. The breakdown of patients in the cohort that was propensity matched was about 2/3 cancer, 1/3 Crohn's disease, and 1/10 of UC. And it's notable that there were 4 major bleeding occurrences in the rivaroxaban group with the procedures or interventions listed there. Next slide, please. These are the results that were presented in the paper. So on the left is the propensity score matching of the 168 patients, where they showed in the historical cohort post-discharge VTE rate of 4.8% versus 0.6% in the propensity score matched group that had 3 actual different groups in it, which was statistically significant. However, in the propensity score matched group of just rivaroxaban post-discharge compared to the historical cohort, that p-value was no longer significant at 0.057. Next slide, please. So in conclusion, there was no statistically significant difference in VTE rates between the rivaroxaban group and historical controls in the propensity score matching. However, there were 4 major bleeding events that required intervention in the rivaroxaban group. Limitations of the study include using a historical cohort, the inability to determine the symptomatic versus asymptomatic VTE, and a lack of compliance data in the prospective cohort, as one of the reasons for conception of the study was that the rivaroxaban once daily oral injection may be actually easier for patient compliance. And this sort of sets up, as we talked about, a potential for a future 3-arm or randomized control trial that compares a direct oral anticoagulant to what we use now commonly versus a placebo as well. Thank you. And I'll take any questions in discussion.
Thank you very much for that. Dr. Goffredo, can we have you say a few words?
Yeah, of course. Thank you, of course, and good job, Alex, in presenting this paper very nicely. I think the manuscript is very timely, as oral anticoagulation is becoming more commonly used, and the advantages are obvious to avoid the poke. So the question becomes, why not using it more often? And I think this paper adds to the body of literature that's building around it. And it's kind of, from a clinical standpoint, raising more concerns than potentially offering opportunity for our patients. If you look through the data that Alex has presented, the rate of reportable bleeding is more than double in the interventional arm, 7 versus 3%, while there is no statistical difference between the 2 preventable outcomes when the authors actually look at the right comparison, which is a patient who got the rivaroxaban post-discharge. Moreover, 1% required reintervention for major bleeding. This is in line with a trial that a group of Italians conducted 2 years ago, the Prolapse 2, which showed exactly the same results. They randomized 500 patients that underwent colorectal surgery to rivaroxaban versus placebo, and they found no differences in major DVTs, but they found 1% of them require major intervention. So our group at that time wrote a letter to the editor of Blood where this paper was published, because we did think that the signal of harm was quite significant. So I think if you take those data all together, they kind of all point in the same direction, both the retrospective cohort that Alex has presented, the randomized trial that has already been published, and together also with what the Mayo Clinic has published with the rate of VTEs being so low. I think it's definitely not prime yet for anticoagulation, as the risks seem to outweigh the benefit. Here at the University of Minnesota, was very lucky. We have an evidence-based center of excellence that we collaborate with very often within the School of Public Health. We have randomly just finished a systematic review on VTE, and Alex was the lead author on that. So he has become an expert on assessing the strength of evidence and looking at papers. So I'll leave him talk a little bit more about the methodology. And if there is time, maybe he can present one slide with our results.
Thank you, Dr. Fredo. Yes, so we were able to sort of scour the literature with the help of a certified librarian and look at all papers that dealt with VTE in colorectal cancer and IBD, looking at rates, but also we tried to determine symptomatic versus asymptomatic rates and things. And there's, as we've alluded to, wide variety in the literature. And so we were able to ultimately include 38 studies, 4 of which were randomized control trials, and assess that evidence for VTE rates, but also compliance and the major bleeding that we talked about. Compliance literature is extremely poor, and VTE rates are variable, as we talked about. from 0.2% all the way up to 9.7% in some cohorts. And so it's really about critically evaluating that evidence and building it into something that would be a document that people can use going forward. Because as we said, this is an area that has limited high quality, methodologically rigorous studies. And I think that's what our systematic review showed.
Thank you both. I'm going to ask a few questions to the panel because sometimes the sort of clinical applicability of these challenges when we anticoagulate patients is not straightforward. So one of the other papers we featured this week was called tafasitinib is associated with increased risk of postoperative VT in patients with UC. Now, in that paper, they talk about the rate of portomesenteric venous thrombosis. In my experience, I've sort of seen this most in J pouch formation, but I guess it can be with total colectomies or other abdominal surgery. How do you manage SMV or portal vein thrombosis in the perioperative setting? And should it come under VTE, or is it a different beast?
I'll just say the times that I've seen it, it's very similar to what you were saying about a J pouch. Occasionally when somebody will get a CAT scan after surgery nowadays, after especially a very prolonged pneumoperitoneum, for example, you'll see these and we'll present them at M&M. But what I typically do is assess end organ perfusion, right? So I'm mainly looking for synthetic liver function. And first of all, ruling out any type of intestinal ischemia where something needs to be done either operatively or endovascularly or from an interventional radiology standpoint, where they need to have catheter-based lytics or something like that. I have never had a case where I've had to intervene for that. I'll just say that. The other ones, even when it's asymptomatic, they get referred to hematology. They get a hypercoagulable workup, which they typically don't want to do right after surgery. They want to wait before that. They will be discharged on a more robust anticoagulation kind of protocol, which is typically 1 milligram per kilogram of low molecular weight dose heparin. And once their hypercoagulable state has been at least assessed, if they don't have any other major risk factors or an actual diagnosis of hypercoagulable state, most patients will get 6 months of anticoagulation in a therapeutic. That's typically what I've seen, but I really have not seen a lot of data on this.
Thank you very much. The next question kind of sort of if we cover the patients who are therapeutically anticoagulated. Now, I'm not sure. Sometimes I wonder if that's because there's too many cardiologists in the area where I work rather than the patients. But hypothetically, if we're facing a patient with a mechanical heart valve, and so the impetus is to re-anticoagulate them as soon as possible after surgery. How do you approach that in your institution? Is there a protocol? Is this titrated per specific surgeon, specific cases, etc.? Anyone on the panel, please feel free to answer.
It's more of the latter. We definitely tailor it to the patient and the specific risk factors. Of course, with the mechanical heart valve, we're very quick at jumping on the patient and maybe not restarting oral anticoagulation that are not reversible, but starting, of course, with an heparin drip or Lovenox injection that can easily be reversed.
Yeah, for our hospital, almost universally use straight heparin drip. So we have protocols in place depending on how high risk of a bleed that patient were, depending on what operation and their history. But we'll start them on a heparin drip, something we can shut off or reverse within 4 to 6 hours of surgery for a valve.
Thank you. Now, sort of talking about unfractionated heparin versus low molecular weight heparin, is there a role for unfractionated heparin in any other event, or is it really just the heparin infusion that we use it for? The reason I ask is sometimes I wonder when I worry about patients being hypercoagulable, for example, toxic megacolon, I sometimes give unfractionated heparin, but I give it more frequently than I would sort of enoxaparin. And again, I have no real basis for this. It just makes me feel a little bit better. But have you thought about that? Do you do anything similar?
So I use it for renal failure patients, right? So if somebody's on dialysis, they're going to get sub-Q heparin versus Lovenox. And that actually the data on that is not as good either, but it circulates obviously. And if they're on dialysis, it's probably not going to be a big issue anyway, to be very honest. And then I usually, if it's a renal patient, I usually dose it BID, and I don't have a lot of supportive literature for that either. But I typically don't order sub-Q unfractionated heparin once daily, though. I either do it 2 or 3 times a day.
Yeah, thank you. So yeah, I tend to, if I'm worried, I give it 3 times a day, and I think it's probably slightly more than enoxaparin, but yeah, it's a bit of witchcraft. Now, the other question I have, now if I look at the CPG guidelines in relation to IVC filters, there is a recommendation against IVC filters in prophylactic scenarios. Now, I don't quite understand if someone who has a known DVT who needs to undergo an ultra-low anterior resection, for instance, is that a prophylactic scenario, or is that a therapeutic scenario? And so how would you face a patient with a known sort of DVT, large DVT, and you need to do surgery on them, and obviously lower limb DVT?
Mark, Paulo, who do you guys usually do a filter on?
That is someone that I would use a filter on. I don't think that that's prophylactic. That I consider as, so for me, prophylactic piece, like, I don't know why you couldn't put someone on, but like if you, for some reason, you couldn't put them on an anticoagulant afterwards, I can't even think of a scenario where that would happen. But if someone had a large DVT, I would put a filter in pre-op and then start them back on anticoagulation relatively quickly after surgery, or as soon as I could.
Only if the DVT was a long time ago, I would consider not placing a filter. Like let's say it was 3 or 6 months ago, and then they're kind of in the window where you may stop it. But otherwise, they're getting a filter as well.
Yeah, I would probably echo that. And so if somebody has a history of a DVT or VT in general, if they have a floating component of a large DVT in a major vein, so if they like iliac femoral, if they have something that's iliac or femoral, which this is supported somewhat from the literature, majorly from surgical oncology, if they have a floating clot, either it could be lower, or if they have a large iliac femoral component of it, those are the patients I feel very strongly about a filter. And in that case, I don't see it as prophylaxis.
Okay, thank you. I think that I think that's certainly helpful and clear. I think in the interest of time, unless someone has any other questions or comments, I know that there's one comment in the chat about sort of mixing IBD and malignancy in the same paper. I personally think it's probably to increase numbers, because certainly it does increase variability as well. But assuming that there's nothing else, let's move to the poll and then the special guest segment. So Stephen?
Yeah, so I'm sharing the results. So both, the participants all pretty much had very low rates. I found, I don't get to answer these since I run this poll part, but I did find myself wondering, about, there's, been a couple patients over, a handful of years where we did not, the family didn't want an autopsy and they had a rapid death, after my or someone else's surgery. And I've wondered, but I don't know if I could identify a patient that I knowingly had die of this, but I think that was the assumption in at least one case that comes to mind.
Yeah, thank you. I put up another I think that part of the slide has somehow disappeared, but I put up a photo from the CDC website, which states that 1 in 10 hospital deaths is related to PEs. And so that's the American CDC. Interestingly, the Australian one mirrors it. I'm sort of obviously a little bit biased towards the Australian data, and so I then looked into, what do they justify that by? So if you look at the comparisons by deaths, that's what the Australians base it on. So VTE was higher than deaths from bowel cancer, deaths from diabetes, deaths from AIDS, which I thought, if I was going to pick one, probably would pick a VTE in terms of risks to my health. It just seems kind of what I see in hospital with my patients compared to what I see published. There seems to be a significant discordance. Would you agree with that, or do you think that the incidence of deaths is truly 1 in 10? I don't know. Like I kind of worry that a lot of this data, and this data is then based on what we do, is sort of deaths with VTE rather than deaths from VTE.
100%. It's a lack of it's association, not causation.
Absolutely.
Yeah, thank you. Makes me feel more sane. All right. Now let's move on to the next component. And so the next component is the special guest component. And so the person which would want to highlight is Professor Gaertner. He is, of course, the chief of colon and rectal surgery at the University of Minnesota. He holds the Stanley Goldberg MD Endowed Chair in colon and rectal surgery. He is actively involved in both clinical and translational research, and he currently serves as the chair of the Clinical Practice Guidelines Committee for ASCARS. And honestly, it's I saw him chair that committee session at ASCARS, and I had the idea of hopefully getting him to talk about that a little bit at one of the journal clubs. So I'm very grateful that that has happened. And so the first question that I thought would start off with is just more of an introduction question. So if I look up your profile on X or Twitter, as it was called, there seems to be 3 flags, being Mexican, Canadian, and German, which is quite a unique combination. So can you please tell us a bit about your background and what makes you you?
It's a question I get frequently, and it's mainly, I should probably just put the Minnesota flag and a picture of Stan Goldberg right beside it, and that would be better than those 3 flags. But the short answer is my parents are German. I grew up in Mexico, so I'm the perfect spy. When you see me speaking Spanish at ASCRS with all of our Latin American members, that's the reason why. So I grew up in Mexico. And so I lived in Canada, but my main home is Mexico.
Interesting. So, certainly, I found that my name and accent presents a lot of confusion for people. So I'm empathetic to that. So the next question is about the CPG committee. So can you please tell us what is the makeup of the CPG committee, and what goes on behind the scenes to produce the guidelines, and how long are the terms, etc.?
Yeah, it's so the CPG, the Clinical Practice Guideline Committees of ASCRS, is probably the largest, most robust committee within our society. We currently have 47 members, and that's including obviously a chair and a vice chair, Tracy Hedrick, and Ian was the chair that just stepped down. But what makes it up is that it's a working committee. It's probably the committee where you have to work the hardest, but there's a lot of benefit in that. There's a lot of reward, especially for those who are searching promotion. By large and far, and Susan can probably tell you this too, that probably the most quotable papers that come out in DCR are the clinical practice guidelines. But it's a working committee. So typically when there is a topic that's up for renewal or an update, we assign a lead who is a person that has usually been on the committee for at least 2 terms, which would mean 4 years because each term is 2 years. And they have led other side projects in the past. And each team consists typically of about 4 to 5 members of that committee. And they put together a whole construct of how to either reformulate, edit, add or subtract from the CPG. And that whole process of doing a bunch of Zoom meetings to figure out what are going to be the most updated statements, the literature search, the writing and the rewriting, and then I have to submit it to executive council. It gets rewritten at least a couple of times. Then it gets submitted to DCR. It gets rewritten multiple times after that. That process is probably a minimum of a year. So very active working committee, but very rewarding.
Thank you. So we've touched on it before with, people from all over the world having access to internet, and therefore we can get data from different groups. And so clearly the world is becoming more global and smaller. And so the members of the committee are becoming international. Like I was fortunate enough to get on, for instance. And of course there are positives of that. But I wonder if that risks making the guidelines less relevant locally. How do you find the balance, and is that a real risk?
I don't know if I see it as a risk. I feel like it's something to keep in mind when you're writing these things, because CPGs have never represented what's the standard of practice in your community. It's the standard of practice based on the grade of data. So we use English published data, no matter where it's published, as part of our grading to either support or refute a certain statement or annotation as part of the guideline. You've said it. I mean, you have it on your phone, right? You can find it immediately. And I'll repeat myself by saying we're not there because perhaps we're not the expert. And for example, I'll just say, just because it's part of my practice, HIPEC, for example. Perhaps you're not going to find the expert of HIPECs writing the HIPEC CPG. What we're there to do is to grade the data and present it in an unbiased fashion. And I think that's the best statement you can get, especially for society, no matter where it is. And I think it's good for our global community to have more members, international members, as part of our committees.
Thank you. Let's take the HIPEC idea. Say we're updating the guidelines on colon cancer, and a component of that is related to HIPEC. So how does that work? Do you get a specialist to then sort of work with the guidelines committee or not? Yeah, I'm just curious in terms of how that works.
Yeah, I think so. Danny brought this. Actually, Scott probably brought this on. That's how long I've been on this committee. Scott Steele probably brought this on at least a decade ago, where there has to be an ad hoc reviewer for each CPG, and sometimes up to 2. So we select people that are expert in the field that may not even be a colorectal surgeon sometimes, to review it before we submit it to DCR, in between executive committee and DCR. And I think that's very, very helpful, because most of the time we try to pick people that are not in our immediate circle, not in the committee, and it's been gratifying and helpful for overall the quality of the CPG, but it is standard.
Thanks. When I looked at the VTE guidelines preparing for this, if I search on them, I get a list which is intimidating in the amount of guidelines which are out there. Obviously, some are more niche for colorectal surgery, but there are still a lot of societies that produce guidelines. And so how do you pitch the guidelines, the ASCARS guidelines, compared to others?
I think the special sauce of ours is probably directed towards the colorectal surgeon, right? So dealing with like the specific disease processes that we deal with, not excluding the overall pathology, physiology that we would normally look at for any type of disease process, but it's for the working colorectal surgeon on that is day to day what is helpful in their practice. I think that's probably the best thing that I can explain. If anything, I'm trying to make CPGs more digestible and eliminate recommendations such as everybody with hemorrhoids should have a history and physical. We get it. That's important to ask people about certain things that may contribute to hemorrhoids or to colon cancer, but to focus it more, because we're all going 100 miles an hour nowadays. We have less and less time to review these things. We have to make this more appealing to the readers, to our readership, our global readership, and to our members. So what we focus on is ASCAR's members, and we ask for feedback on how they think these CPGs are constructed. And probably by and large, the best feedback that I've received is that they're too long. They're hard for me to read. I can't access them rapidly. Most of our CPGs are on ASCARS U. If you haven't used ASCARS U, it's a very easy tool to go to and obtain the most up-to-date CPG and click through it. But they want something that's more digestible, almost like an online document. It happened to us in rectal cancer, where we essentially had to rewrite the guidelines after 6 months because there were so many new papers coming out and studies coming out that a lot of the statements had to be changed.
That's very interesting. I'm going to close with the last question. I guess, as the proverb goes, with great power comes great responsibility. And so you being the chair of the guidelines committee, what do you see as the direction for the CPG committee in the next, say, 5 or even 10 years? Where do you think it'll go?
I think it's going to become more and more robust. I think we need more people participating within the committee. These are projects that can take a year, and sometimes just having 4 or 5 people just reviewing is not enough. So if anything, I hope we have more participation of our members, more international global presence within our international, within the CPG, and probably instead of having more of a published CPG, an online live document that we can continuously update depending on the grade of data.
Oh, that's very interesting. Well, thank you very much for the whole panel and the team from the University of Minnesota. I've certainly learned quite a bit, and I hope it's been useful to our audience or to the viewers on the YouTube DC&R channel. We'll have our next session in the end of November. It's going to be on Sunday because it's international, and so it's hosted in the UAE with some international guests, and we're going to focus on fistula in ano. But again, thank you all. Have a good evening, and hopefully see you face to face at next ASCARS meeting or something. Okay.
See everyone in San Diego. Thanks for having us.
Fantastic. Bye.
Thank you.
Thanks.
Thank you.